Now let us start with the cardiovascular system. In cardiovascular system, what is the action potential that goes through each muscle fiber? Now remember, in myocardial cell, this is the depolarization that it undergoes. In this, remember that there is phase 0. Now in phase 0, there is sodium depolarization, just like our normal nerve conduction that we study. Now after that, phase 0 is sodium conduction. Now phase 1. Now in phase 1, what happens is that there is a stoppage of sodium channel, and in phase 2, and in phase 1, what happens is that potassium channel opens. Now after the opening of the potassium channel, now we move on to the phase 2. Now what happens in phase 2? Remember that in phase 2, it is the plateau phase. So what happens is that potassium channel is already open, but calcium channel also opens, and therefore both balances out their electrical charges, and therefore the charges do not change in cardiac muscle fiber. Now when we move on to the phase 3, what happens in phase 3? In phase 3, calcium influx has stopped, but potassium efflux is continued, and since potassium efflux is continued, this will lead to repolarization. This would be under the repolarization phase. Now we move on to the pacemaker potential that we see. In pacemaker potential, we can remember it by the mnemonic funny cat. Remember, there is pacemaker action potential. What happens in phase 4? In phase 4, we have the funny cat channel. What is funny cat channel? That is, there will be fast type of calcium channel, T-type calcium channel in the phase 4. And also remember that there is a Now remember, in phase 4, it is the sodium efflux is sodium influx is counterbalanced by potassium efflux, and this is happening on one side, and then there is a slow depolarization also occurring by the phase 4 long funny current of calcium channel, that is T-type calcium channel. But as soon as we move on towards the phase 0, in phase 0 is known as depolarization phase. But what happens here is that the opening of long L type of calcium channel, And again, when we move on to phase 3, in phase 3, potassium channel opens, and it gets effluxed, and then it leads to repolarization. So how does the heart function? Like adenosine. Now how does adenosine function? Adenosine, what it does, it decreases the heart rate. What it will do is it will decrease the pacemaker potential. Now we move on to the most dreaded part, that is very much that is Now we move towards learning the antiarrhythmic drugs. What are the antiarrhythmic drugs? Now first we will move on to see the class 1 drug. Class 1 drug are what? Firstly, class 1 drug is a sodium channel blocker, in which 1A is both sodium and potassium blocker. 1B is sodium blocker but potassium opener. 1C is only sodium blocker. So what will it do? See, when it is blocking the sodium as well as potassium, so in the depolarization phase, its slope will also get reduced, and also since potassium, it's a repolarization plateau phase, and the repolarization phase would also flatten out. Now class 1B is sodium potassium opener. We have here maxilitine and lignocaine, and what it does is that here sodium blocker, it is blocking the sodium channel, so the slope of phase 0 is decreased, but it is opening the potential, so the time period reduces of action potential, whereas the propafenone is exclusively sodium channel blocker, and it only alters the slope and nothing else. So how to remember what are the drugs associated with particular class? So remember, Queen proclaims disopyramide, that is quinidine. We have here quinidine, proclamide, and disopyramide. Now 1B is potassium opener. Now in 1B it is maxilitine and lignocaine. In this, what is happening is potassium is moving out of the cell. Just remember that potassium is something that is, we can write pot. Now when a pot it is filling maximum maxillitine, and it is having a lid, so lignocaine. Lig is equal to the lid. You can substitute that much, and from that you can remember this. Now we move on to the 1C, propafenone, flecainide, monocysin. Okay, so how will you do is that more falak tak. So more monocysin ho gaya, falak flecainide ho gaya, and propafenone, just remember that. Now we move on to the class 2 drugs are basically beta blocker. Okay, before moving, there are certain things that you should remember, that in class 1B is for ischemic arrhythmia, and class 1C is contraindicated in ischemic arrhythmias. So when we write ischemic arrhythmia, we write 1A, but for 1A it is not 1A, it is 1B, and for and 1B the contraindication is 1C. So by that you can recall yourself. Also 1B is used in digitalis toxicity. Why 1B is used in digitalis toxicity? See, what happens in digitalis is that it blocks the sodium potassium channel first. Second, it causes in heart, it causes blockage of AV bundle, AV node. So so ultimately what it is prolonging. But class 1B drug, the action of class 1B drug is that it increases the action potential depolarization. Now when it increases the action potential depolarization, it will reduce the duration of action potential. So the ultimate duration of action potential, this is reduced, and this helps in overcoming the arrhythmia and the blockade produced by the digoxin. Now we move towards beta blocker. Now beta blocker have esmolol. Now what happens in esmolol? It ultimately reduces the heart rate, and when it reduces the heart rate, what it does is, so it can be given in tachyarrhythmias and all. Now we move on to the potassium channel blocker. It can be remembered by the mnemonic aids. What happens is that amiodarone, ibutylite, dofetilide, and sotalol. And after that we can remember the class 5 as 4 as type. And also remember class 2, 3, 4. You can remember this by Buxa. That is potassium channel. Sorry. Beta blocker, potassium channel blocker, calcium. Or also you can remember that 2 into 2 is equal to 4 is equal to calcium. Calcium belongs to class 4. What method you can remember this? So what is the mechanism of action of adenosine? Adenosine is often used in paroxysmal supraventricular tachycardia. So what is pathology? Main pathology here that it is here that tachycardia is happening. So what we will do? So we will do what? We will give adenosine. What does adenosine does? Adenosine blocks sodium channel and opens potassium channel. It acts on both, and basically it acts on phase 4 of the sinoarterial pacemaker generating potential. And also remember that the action of adenosine is blunted by theophylline, caffeine. See, in class 1C it is only sodium blocker, sodium channel blocker. So it is just 1C is largely given for maintaining SA node rhythm. So sodium is blocked but no action potential, and this way excitability increases, and therefore it has pro-arrhythmic potential and avoided arrhythmia or ischemia. Now there is one really important drug, that is amiodarone. Now many of the times as the side effects of amiodarone is asked, so just remember what are the side effects of amiodarone, and then we are through antiarrhythmic. So you remember, please check your TFT, LFT. Now what we can write now for amiodarone, we can write that please check LFT, TFT, and PFT. So how can you remember what is this for? Now amiodarone can cause phototoxicity. So remember that in amiodarone we can check by please check LFT, TFT, and PFT. In this what happens is that there is phototoxicity, there is corneal deposits, there is liver function affected. Then in thyroid it can cause both hyper and hypothyroidism, and in case of pulmonary function test you can get pulmonary fibrosis. Amiodarone can also cause pulmonary fibrosis. Now as we are studying arrhythmia, now let us move on to the paroxysmal supraventricular tachycardia. So what happens is that what is the flow chart we can make from it? Either the patient is so in paroxysmal supraventricular tachycardia, if a patient presents to you in emergency, if the patient is unstable. So remember, in most of the arrhythmia, whenever the patient is unstable, you can give defibrillation, and when it is stable, then we can first try the vagal maneuvers. If vagal maneuvers do not function, then we give adenosine, and if again adenosine do not function, then we can give beta blocker or calcium channel blocker, that is verapamil, and from it patient can be controlled. If after this patient is unstable, then we will again move on to the path of defibrillation. Now many of you have not noticed, then I have deliberately done a mistake here, that here it is not defibrillation, it is synchronized cardioversion. I did so because many of the students don't understand between the difference between defibrillation and synchronized cardioversion. So when in PSVT we will do synchronized cardioversion. Why? Because remember that in synchronized cardioversion it is used in sustained ventricular tachycardia or supraventricular tachycardia, unstable cases, atrial flutter or fibrillation, whereas defibrillation is used in ventricular tachycardia and ventricular fibrillation without a pulse. The shock is delivered in sync with R wave. The shock is delivered at any time during a cardiac cycle. Therefore, it is called synchronized sync with R waves. Now, what are the characteristics of QRS complex that you would get in cardioversion? Narrow and regular, narrow and irregular, wide and regular, and wide and irregular, no synchronized cardioversion. See, remember, Defibrillation is mostly used in with respect to the ventricular part of the heart. Defibrillation is used in respect to ventricular part of the heart, whereas synchronized cardio version is used with respect to atrial part of the heart broadly. See, if after ventricular tachycardia, ventricular fibrillation, again there is no sustained, it is not accelerating, then again we go towards the sustained cardio version, synchronized cardio version. So here is a question related to arrhythmia. A 32-year-old man is brought to the casualty after he develops sudden onset dyspnea, chest pain, and palpitation at a party. His blood pressure is 100 by 62 millimeter of mercury. His ECG is shown. What is the drug of choice to treat this condition? So what do you make of this ECG? So how we should proceed? Just okay. First take the lead AVF. We should start with AVF. So, but in C lead AVF. First, we will try to find out what is it. It is tachycardia or bradycardia. 300 divided by, it is less than 2 squares. If you say 1.5 square. If you round about, you will still about coming to 2. Then also you will get around 150 heart rate. That is tachycardia. Therefore, there will be tachycardia. Now, after doing this, let us see where is the P waves. There are no P waves visible. Only QRS wave complex is visible. And there is tachycardia. So what does it indicate? That since PQRS is not P is not visible, that means the pathology lies above the ventricle, that is auricle, that is atrium. So how will the atrium tachycardia, and it is supraventricular. So supraventricular tachycardia, what we get. The drug of choice for PSVT is adenosine. So, and what are the other ECG features that help you identify that it is PSVT? That is pseudo R1 present in lead. V1. Now this is the second question, that a 68-year-old me admitted to the ICU for acute exacerbations of COPD develops a sudden onset of palpitation. The following ECG changes are seen. What is the most likely diagnosis? See, first we will see whether it is tachycardia or bradycardia. Now let's divide 300 by the number of squares between R and R. Now there are maximum 2 squares, so 250, so it definitely is a tachycardia. Now we have to find out which type of tachycardia. For that we see the QRS complexes, that is narrow, and now we see the P complex. Now P wave is also multimorphic, that is they have different shapes and sizes. That is why this is known as multifocal atrial tachycardia. Now one thing also you have to remember that MAT, we use MAT in our home, and that MAT often releases a lot of dust, and when this dust is released, then it causes respiratory symptoms. So MAT is associated with COPD. So whenever a question comes in which they are giving MAT, then be a little bit thinking about the respiratory symptoms. See, like here it has given in the question that acute exacerbation of COPD. Even if you did not have this graph, and then also you would have to mark this answer, you could have easily marked multifocal atrial tachycardia, because it is the one which is associated with COPD. So try to learn the other stuff that are associated, and that will help you in correctly diagnosing the exam, because ECG is a tricky thing, because we are not cardiologists yet, and ECG don't come so easily to us. So these are the hacks that you can use. Now in case of ECG, you have to remember that now in ECG we have PQRS-TU complexes. Now how will you understand? Firstly, PR represents atrial depolarization, and it is around 0.12 seconds, and then we have QRS interval. Now that QRS interval can be 0.1 to 0.20 seconds, and the J point is the isoelectric point. And remember that if in ECG, first we discuss the abnormalities of the P wave. Now what happens in abnormalities of P wave? See, if P wave is large, see what we see in the abnormalities of P wave. Suppose this is the SA node, this is the AV node. Now what happens if there is right atrial hypertrophy? When there is right atrial hypertrophy, then the P wave becomes enlarged, because it has to travel a greater length of the segment. But when therefore we get tall P waves in right atrial hypertrophy, whereas in left atrial hypertrophy, remember that here the impulses will, the first impulse that is going to come from SA node to AV node, it will come directly. So we will get the first peak here. But what happens is that the rest of the peak, that is since left atrium is towards the side a little bit, so when it reaches the AV node here, then here it has just reached its peak. Now it was going dipping. Now what happens is that it again rises, and then it falls. So what happens? It appears like a bifid appearance. Now we come on to the next part, that is what happens with the QT interval. Now QT interval is 0.4 second. So remember that QT interval is 0.4 seconds, and QT interval is often used to see the outside D point is diagnosis. So what happens is that QT interval, when the heart rate increases, or when heart rate is moving towards the outside D point is, then the QT interval can abnormally be short. So it will not help us diagnosing the extent of the damage occurring in outside D point is. So we need corrected QTC interval. So for corrected QTC interval, what we will do is that whatever the QT interval that is being calculated in the graph, that is we will take, and then we will divide it by R minus R dash, and this is known as Budget's formula. This is for corrected QTC interval. See, a rise in heart rate is associated with the shortening of the QT interval, and similarly a slowing of heart rate is associated with a longer QT. The Budget formula corrects the measured QT interval to a value QTC attributable to a heart rate of 60 beats per minute, thus providing QT interval value that a particular patient would theoretically have if their heart rate was 60 beats per minute. So remember that is QT is equal to dash upon RR interval. Now we come on to diagnose the how to determine the what axis deviation the heart is having. That is right axis deviation, left axis deviation. It is very confusing. So just listen to the concepts here. So what happens is, in heart, there are three leads that are present there. That is lead 1, lead 2, lead 3. So what is their orientation? First, we will have to understand before going towards the axis deviation, we must understand the into one triangle. So what happens is that this is lead 1, and then this is lead 2, and then this is lead 3. So this is from the right top of the heart, right side of the heart, and this is the left lower limb, this is the left side of the heart, and this is all the arrangement. Now when you bisect it in between, then we will get here AVF. So remember which axis deviation it is occurring. You have to see heart from two sides. That is from the lead 1. That is from here you are seeing. Think of somebody seeing the heart from the right shoulder and AVF. And think of somebody seeing the heart from the, for example, just visualize that somebody is seeing through cubic symphysis, though it is really odd and funny, but that is the case. Now how we will go about and how that will help in assessing our axis deviation. So remember, so we will take two leads for axis deviation, lead 1 and lead AVF. Now remember, so now when lead 1 and lead AVF both are in the positive direction, then it is said to be normal. When lead 1 and lead AVF, that is AVF is leaving away. Now when AVF is leaving away, that is left axis deviation. When lead 1 is reaching out to the AVF, then again it is right axis deviation, and this, and when both are negative, then it is extreme axis deviation. Now remember, in earlier I have talked about one PSVT. Now again I will let you go through it. Firstly, now this is RR1 not equal to, see, this is PQ, this is R, now this is R. Now when we are calculating the RR interval, this is suppose comes out to be 1, RR interval 2, this is RR interval 2, this is RR interval 3. So what is happening here, that RR1 is not equal to RR2 is not equal to RR3. So what does it indicate? This is the characteristics of atrial fibrillation. Now remember, since RR1 is not equal to RR, this is linked to atrial fibrillation, but one thing that is you will be noting that here the disorder is of rate or rhythm disorder, rate and rhythm disorder that is happening. So what drug we will give? See, if the patient is unstable, you will go for synchronized cardioversion. But suppose if the patient is stable, so we will go for a rate control strategy, that is we will give beta blockers like esmolol, or also we can give Electrolyte. Now we move towards the second part, that is, what is it? This is, see, again I'm telling you, first we will get to the, that is whether it is tachycardia or bradycardia. So just see R and R, what is RR interval happening here? So if you see the big squares, it is the one big square here, this is 1.5 and this is 1. So remember that if the count, if 300 by is something less than 2, if something is less than 2 here, then we are dealing with tachycardia. So one thing is clear, that it is tachycardia. Now I will have to see now which type of tachycardia. So QRS wave is narrow, but apart from that we are not getting clear P wave. See, here this suppose here this was the P1 wave. Now P1 wave, P1 QRS T. Now here again P2 QRS T, P3 QRS T, P4 QRS T. So when you see the P1, P2, P3, these are having multiple foci of generation. Therefore, we are getting the shape irregularly. For example, understand that in multifocal atrial tachycardia, this is the ventricular part, atrioventricular tail bundle of his and all. So here the path is sorted. Here there is not one dysfunctional path. The path is here not clear. That is, sometimes it is starting from here, sometimes from here, sometimes from here. So it is multifocal, multiple foci. So what is multifocal? For multifocal, it is verapamil. And if you can relate this in our with our in CNS mnemonic, that verapamil was also given in a particular type of headache. If you can recall, that was the cluster headache. Now cluster headache, cluster. Now cluster, we often see that cluster is often found around the mills that are sugar mills or a clothes mill or anything. So cluster are there. So we give mill here. The purpose of using mill was that here it is mills. So now cluster and mills, these are going together. Some likewise multifocal, something that is going to do with foci. Cluster ultimately it will form a focus. So verapamil is the drug of choice in both cluster headache as well as in multifocal atrial tachycardia. Now we move on to the next disease, that is atrial flutter. Now what happens in atrial flutter? In atrial flutter, RR1 not equal to R1 is equal to R2 is equal to R3, and now it is a sawtooth pattern. So remember that here the ventricle is 1 to first calculate let us the heart rate, that is RR interval, that is 1, 2, 3, 4. Now here it is 300 divided by 4, so it is neither tachycardia nor bradycardia. Now in atrial flutter you will see this. That would be there is we see that there is tachycardia, since there all intervals are equal, that is RR1 is equal to RR2 is equal to RR3. That means we are dealing with here atrial flutter. So what is the drug of choice that we will give in atrial flutter? See, remember that if the patient is unstable, you will give synchronized cardioversion. If the patient is unstable, you will give synchronized cardioversion. But if the patient is stable, just like what we did in atrial fibrillation. See, treatment for atrial flutter and fibrillation is the same, although the diagnosis, the name of the diagnosis may change, but the treatment differs. So for the stable patient, what we will do, we will give either esmolol or Electrolyte, because we are focusing here on rate and rhythm control. Now we move on to the next disease here. This is PSVT. How we can reach to this diagnosis? Again, as I talked earlier, that it is tachycardia, it is supraventricular, so ultimately it will be adenosine But as told again, we will follow a certain step here. The drug of choice is okay, fine, we can give adenosine, but there is a procedure that we follow. If the patient is unstable, we will go for a synchronized cardioversion. If the patient is stable, then we will go for first vagal maneuver, that is carotid massage, and then we will go for adenosine, and then if then also not control, then we can have two steps here. That is, we can give verapamil on one hand, or we can give beta blockers on another. If again the patient is not responding, then we can again go for synchronized cardioversion. So this is PSVT. Now we move on to the. Now remember that when we are getting no discernible rhythm, then this means that forget about atrium. We are thinking about that the ventricle is even not contracting properly. When ventricle is not contracting properly, then it means that it is just dealing with real defibrillation, ventricular defibrillation. So if an unstable patient comes, so what we will do, we will give synchronized cardioversion. But if the patient is stable, then we have two options. We can either give amiodarone or lignocaine. How to remember this? See, defy. When a certain class of people defy the general consensus in an order, then the people who are rich, they will show their power. So, Amir se daro. Low income group walon. So please don't take it as something that is slogan that is for personal life. It is just only for the sake of remembering here. You can think that okay, fine, we are defibrillating what defy, and so when defy is what you will do, you will give them some stern warning, like the rich people of the society, or to the low income group people. Remember up till now that what we have discussed, these are all narrow QRS complexes disease. But now this is wide QRS complex disease. So it is ventricular fibrillation. This is again ventricular tachycardia. So this is ventricular tachycardia, and this is long QT syndrome. Now what is long QT syndrome? As we had discussed earlier, long QT syndrome is referred to as torsitis depointis. Now remember, Romano syndrome will have no sensory neural hearing loss. Jervell, Lange, Nelson, then you have sensory neural hearing loss. And what is the drug of choice for torsitis depointis? Remember, it is magnesium sulfate. What are the drugs that predisposes to torsitis depointis? Remember that we have macrolides, chloroquine, fluoroquinolones, and we have antiarrhythmic drug. Now we have antiarrhythmic drug that is belonging to class 1A and 3. These both class of drugs are prone to causing arrhythmia or torsitis depointis. Just for the sake, what was the mechanism of action? That in sodium in 1A there was sodium as well as potassium blocking activity, whereas in class 3 what it was? Again, it was only potassium channel blocker. So whenever there is potassium channel blocker anywhere, so what will it do? Potassium channel blocker will lead to reduced efflux of potassium. When there is a reduced efflux of potassium, membrane will not read the repolarization efficiently. It will not be repolarized, and when it not be repolarized, then there will be increased depolarization, and when depolarization, it can manifest in form of arrhythmia. Now we come on to this scoring system. Now what we do in this scoring system is that congestive failure 1 point, hypertension again 1 point, age greater than 75 years we give 2 points here, diabetes 1 point, stroke. Now here stroke is given 2 points here, and then vascular disease 1 point, age greater than 65 years 1 point, sex category female again greater than 1 point. See, if you see here that sex category field, when we talk about, you have noted one thing that estrogen hormone is cardioprotective. But as soon as female undergo menopause, then what happens is that cardioprotective role declines, and when she reaches up to 65 years, then her chances of myocardial infarction is equal to the 1 in the male. So therefore, in fact, it can increase. So here in this scoring system, there is female sex category, then we have to be extra careful, and therefore if the score is more than 2, we have to switch over to oral anticoagulation. Now we move towards the categories of heart block. Now what are the categories of heart block? Now in categories of heart block, the first category is constant increase in PR. That is, there is, for example, this is P wave and this is QRS, this is T. So P, QR. Now this interval will constantly go on increasing. Suppose this is PR1. Now in second, what will happen? This is again P. This is, so here what is happening, that PR2. Now again we will draw again here, then PR3. So what will happen is that there is constant increase in PR interval, and when there is constant increase in PR interval, what it will call, it is called first degree heart block. What is second degree? For second degree we have two categories, that is Vanky-Back and Movich. Now the second degree first type is known as Vanky-Back. Now in Vanky-Back what happens? That is, one person is going on for Vanky-Back, that is backpacking. What we do? We have in backpacking, we tend to move on for like trip and all, if you have to watch the sunset and all. So what we do? We Vanky-Back, that is, there is constant increase in PR interval, but a point comes where when one of the person does not appear and he is missing, because there was daily increase in the distance, and one day suddenly he or she is not seen. So this will be Vanky-Back. Now second one, Movich. Movich is something that would happen suddenly, because suppose we are on some vehicle mobile, and then what will happen is that there will be no such change in PR, everything is fine, but suddenly you find one day that the other piece, the other person is missing. That is known as morbits. For reference, if you are a movie fan, then you must have seen Gone Girl. In Gone Girl, the wife suddenly disappears. That you can take morbits, and that is also called ghosting. Now, in the third part, we move on to there is complete heart block. In this complete heart block, what happens that atria and ventricles are beating independently. Atria and ventricles beating independently. That is PP interval is constant, but it is independent and it may not be equal to RR interval. So that is known as complete heart block. Now we move towards one thing that we often see is Wolff-Parkinson-White syndrome, and there is a lot of confusion regarding this. So what happens in Wolff-Parkinson-White syndrome? What will the manifestation that we will see? See in Wolff-Parkinson-White syndrome. Now what happens in Wolff-Parkinson-White syndrome? This is P, this is Q, R, S, T. Now what happens is that there is accessory bundle of Kent. Now when there is bundle of Kent, what happens is there is reduced duration of PR interval. Why? Because it has an alternate way of supplying impulses to the ventricle. So what we will do here? Simply we will. So for in emergency purposes, our first drug choice would be flecainide, but for drug of choice would be procainamide. See, if you have seen this movie Leo, then you will be seeing that poster that this actor is having a cigarette, and he's also aiming to control the wolf. So what happens is that, remember that this is cane. That is what that cane that was used in colleges for punishing the students. So what he's doing? He's using procainamide. Now after that procainamide, we can also remember that he's having a cigarette which is made up of the gold flakes. So we can remember that, okay, flecainamide is used for immediate unstable cases of WPW syndrome. So what would be the feature of in heart in cases of WPW syndrome? In that the PR interval will reduces, but the QRS complex will get wider, and there will be presence of epsilon waves. So remember, what would be the parameters that we will get in Wolff-Parkinson-White syndrome? There will be decrease in the PR interval and widening of QRS interval, with the initial part showing the epsilon wave. Now we move on to some others, like my bad here. Just remember, this is not the epsilon wave, this is the delta wave. Now we move on to the other diseases, like, so remember, this is Osborne wave. Now Osborne wave is seen in hypothermia. Now there is another kind of wave that is known as epsilon wave. Now epsilon wave is seen in arrhythmogenic ventricular depolarization. Just again, once again, I would do the epsilon wave. Here it is P wave. Now here we have, now this is epsilon wave. Now when this is epsilon wave, this is based on ARVD disease. Now this can manifest in form of sudden cardiac death. This is seen in familial cases. Now here, this is a new case. What is happening here? Here there is now P complex and QRS and then T wave. So what is happening here is that let us calculate the RR interval. Now RR interval is 1 square, 2 square fully, and 3 square, and then here greater than half square. So here we will take half. Now what is the interval here between the, we will calculate the RR interval here. Now here RR interval is 1, 2, 3. Now if we take little bit of this and little bit of this, so that becomes to be that RR1 is equal to RR2. So that is, we sorted that it is some wider QRS complex disease, because it is he would be having bradycardia, because 500 divided by 3, it would give something that is bradycardia. So now there is bradycardia. Now the point is that why there is bradycardia? Is it because the impulses that is generated they are not being generated, or it is a defect in the pathway? So when we look closely, then we see that there is abnormal morphology of each and every P complexes in the given set. That is, here it is P wave. Now again QRST. Now we are getting confused in here that what is the there is no discernible mechanism. Now when there is no discernible rhythm, then we are talking about this is sick sinus syndrome. Now sick sinus syndrome, what will be treatment? We will go for the pacemaker implantation. Now we move towards the next topic, that here discharge toxicity. But before that, I would like to give an overview that what is happening there. This is PR interval. Now what will happen here? PR interval would be increased or decreased. Now if PR interval is decreased, then we are dealing with nothing but Wolff-Parkinson-White syndrome. But when we see that PR interval is increased, then it can be either of two things. What? Either you are dealing with heart block, either you are dealing with digitalis. Now what happens in digitalis? In digitalis, anything that will have T written over it, that would reduce. That is QT interval, that will reduce. See, in digitalis, anything having T will decrease, but anything not having T will increase. That is, if we say that PR interval, now PR interval would increase here. That is why here I would say that PR interval would increase in digitalis. So PR interval is increasing continuously, now T interval is reducing. Now also in digitalis, what we will see, there is QT reduces, then there is absence of T wave. What we will see, that is absence of T wave, and also what we will witness is that there is a scooping. There is scooping, or there is reverse scooping, or there is reverse stick sign. Now if you see that something is forming like this, this is giving the impression of a hockey stick sign. Now this is a hockey stick sign, or it is also called a Salvador sign or reverse stick sign. So remember, what happens in digitalis, that is PR interval is increased, but the other intervals associated with T are decreased. Now we move towards the other electrolyte abnormality that we see. What is this electrolyte abnormality? The first is there is increase in potassium. That would be analogous to hyperkalemia. What happens in hyperkalemia? That Now see if this is the normal. So what happens in hyperkalemia? There is, see, normally this is P, Q, R, S, T, and this is the normal way. But what will happen is that P wave will start reducing. Now QRS can get a little bit prolonged, but there will be T wave. Now T wave would be increasing in the height. So what we will get? We will get peaked T waves. Now after peak T waves, we can after that little bit of sodium again increases, that is it increases above 8. So what will happen here is that this P would, this, if you have noticed that here the P wave was reducing, but now here it will altogether vanish. More increasing potassium, it will ultimately become a sine wave. So this is what about hyperkalemia. So how will you manage a case of hyperkalemia? Simply we can give, for emergency purposes, we can give calcium gluconate so that we can prevent arrhythmia. Calcium carbonate is not given. That is common misconception of, don't know how. The other drugs that we will give is insulin that reduces, pushes the potassium inside the cell. Beta blocker, beta stimulator, that is salbutamol can be given, that can push the potassium inside the cell. Again, we can use resins that binds to potassium, and in this way we will be able to. And last but not the least, hemodialysis if everything fails. Now we move toward our next disease, that is other electrolyte abnormalities. What will happen when there is hypokalemia? Hypokalemia can also be remembered as underkalemia. When there is underkalemia, what we will get? We will get U waves. So remember that there will be QT prolongation. This is P wave. This is again QRST complex. So what will happen here is that in underkalemia there will be formation of U wave. Now this is U wave, and there is some prolongation here also, that is QT interval. Now what will happen in hypocalcemia and hypercalcemia? Now in hypocalcemia again, what will happen is that this interval, QT interval, will get prolonged. So we can write right here this. This is hypocalcemia, QT interval reduces. So what will happen in hypercalcemia? Now in hypercalcemia, QT interval would reduce. My bad. Here remember that here the QT interval is increasing in hypocalcemia, but in hypercalcemia QT interval will reduce. So remember here this, and this again. So QT interval is reducing here. We also see that there is what are the test for respiratory distress syndrome? What are the tests that we can do that, so that as to prove that lung is not fully matured? That is, first is Nile blue test. Nile blue test, remember that although it is Nile blue, greater than 50% of orange cell. Second is lecithin upon sphingomyelin. Lecithin upon sphingomyelin is greater than 2. Shake test. Now shake test. Bubble test. That is amniotic fluid with 95%. And ethanol, there is ring of bubbles. Now we come on to the most one more part, that is cystic fibrosis. What happens in cystic fibrosis is that, remember that cystic fibrosis, sat is coming. The word sat is being, when we speak cystic, instead of 6, think of 7, and that seventh chromosome is involved. And what are the genes? That is CFTR gene is involved. So in this what happens is that, what are the diagnostic tests? What is the screening test that is often asked with cystic fibrosis? So remember that first is immunoreactive trypsinogen is used for screening. See, for any screening method it has to be easily done. So what happens is that trypsin enzyme is not being able to push out of the pancreatic duct. So what happens is that when trypsin is not being going into the digestive system, so it accumulates there, and then trypsin then comes in the circulatory system, and once this comes in the circulatory system, then it is immunoreactive, because for our blood this is a foreign body, so it will be immunoreactive trypsinogen. Fine, if we see immunoreactive trypsinogen, then this is a screening method for cystic fibrosis. Second, but what is the diagnostic test that we do? See, diagnostic should show directly the disease pathophysiology. So what happens is that chloride is excreted in excess. Chloride is excreted in excess outside the cell, and therefore sweat chloride test. In sweat chloride test, it is 60 millimole per liter is diagnostic. And remember, genetic testing is gold standard. Now, what is the diagnostic criteria of cystic fibrosis that can also be asked? Number 1, clinical system affecting at least one organ system, that is respiratory, gastrointestinal, or genitourinary. Now, as you've said, the diagnostic test, what we have immunoreactive trypsinogen, and for circular test is used as a diagnostic test. For screening is immunoreactive trypsinogen. Genetic testing is gold standard. Nasal transeptal epithelial potential difference can be used to meet in equivocal cases. What are the diagnostic criteria? At least one of the organ system is involved with positive newborn screening, that is, this immunoreactive trypsinogen is positive, and also a sibling with cystic fibrosis. Now, we have to also prove that there is evidence of dysfunction of the CFTR gene by 2 positive sweat chloride tests obtained on separate days, or identification of 2 CFTR mutation by genetic testing, or an abnormal measurement of the nasal potential difference. Now, ST segment elevation is seen in following up the situation, that is myocardial infarction, and then we have Takotsubo cardiomyopathy, ventricular aneurysm, pericarditis, hyperkalemia, Prinzmetal angina. So what are the features of myocardial infarction? Now we move towards the ischemic changes that we witness in ST segment or in ECG. Ischemic changes that we witness in ECG. So first is that is T wave prominence. Now here T wave prominence. Either there will be T wave prominence or T wave inversion. So here it will be T wave inversion. Moreover, now there could be different levels of ST segment elevation. Now here it is slightly elevated. It is more elevated. It is here convex elevation known as party sign. Now there is some presence of pathological Q wave. Remember that pathological Q wave is seen in 2. That is my and HOCM. See, Hakim is illiterate. Hakim is illiterate, therefore he never asks questions Q. And my that is mother. Mother is out of love, not ask question. So by that we can remember both Q wave is from MI and HOCM. Now we move towards pericarditis. Now in pericarditis, remember that there is decrease in PR interval, but the same PR interval, there is depression in PR interval, whereas there is elevation of ST segment in pericarditis. But remember, there is global ST elevation in pericarditis. There is global ST elevation. That is, in all the leads, there would be ST elevation that would be witnessed. Now we move towards the Brugada syndrome. Now in Brugada syndrome, remember that there would be coving off of the ST segment, inversion of T wave, and the isoelectric J point moves upward. Now, what are the different pathologies and what would we get in different pathologies? It is available in the tabular format. Remember, in stable angina, pain will be present on exertion. Troponin will not be there. Infarction will not be there. ECG changes witnessed on exertion. Now, what we can do in stable angina, that we will reduce the work of the heart. How can we reduce the work of the heart? That is by allowing the heart to have more flow of oxygen. That would be by reducing the heart rate. And how you will reduce the heart rate? That is by the beta blocker. Now, unstable angina. There's just a bit change that there can be some exertion, but we largely take it normal. Now, in unstable angina, pain is unrelated with exertion. Again, there is no troponin, there is no infarction. And in ECG, it may be normal or it may show some ST changes. And for unstable angina, what we will use? See, for unstable angina to ST segment elevation, we will use a common treatment. Now, in ST segment ST elevated myocardial infarction, pain would be there, troponin would be there, because there would be infarction would be there, ECG changes. So what will be there? ST changes, elevation, treatment. Again, I would tell it in the last. In non-ST, again, pain would be there, troponin release would be there, infarction would be there, ECG changes. ST segment is depressed in non-ST elevated myocardial infarction, and treatment I will start separately. On infringimental angina, there would be pain. See, in all these cases, pain would be present at rest. It is only in the classical angina that the pain waves will be when the person is doing exertion. Troponin infringimental angina. Since it is an angina, therefore it will be reduced blood supply and pain, but there would not be anything related normal or ST elevated. And treatment is CCP. Now, how to remember all this? Now, in unstable angina, how we can remember? One thing also that you will have to differentiate is that infarction in ST elevated. In ST elevated, there is the infarction is transmural, whereas in non-ST elevated, the infarction is subendocardial. Now, what are the ECG changes we witness in here? See, in this unstable angina, we will give morphine that will reduce the work of the heart as well as reduce the exertion. We will supply the oxygen. We will give the nitrates. In ST elevated myocardial infarction, there's a bit difference in treatment here. Again, what we will do, we will give morphine. We will give oxygen, but here the catch is that we will give aspirin. How much aspirin? That is 375 milligram. Here we will give certain anticoagulants. And same would be the treatment in non-ST elevated, that is morphine, oxygen, nitrate. Now we move towards this is Takotsubo cardiomyopathy. In Takotsubo cardiomyopathy, that is mid-ventricular narrowing. There is mid-ventricular narrowing, and also there is a reduced motion of the free wall of the left side of the heart. Now we move towards the definition of myocardial infarction. See, for myocardial infarction, you can remember the definition by this here. That is for myocardial infarction. Just remember PQRST, that is presumed STT changes or new onset left ventral branch block, manifestation of Q waves, regional wall motion abnormalities seen on imaging, symptoms of ischemia, and thrombus by angiography. Detection or rise or fall of cardiac biomarkers with at least one value greater than 99th percentile. Cardiac death is witnessed, and symptoms of the ECG abnormality that ECG, echo, and angiography. Now in this, what we will do, we will measure serial troponin. Serial troponin is measured. Now remember that more than twofold rise of troponin is a marker for heart and myocardial infarction. Remember that there is heart-specific fatty acids that are the earliest biomarker of myocardial infarction. Now we move towards the branches of the right coronary artery. How can we see? It can be learned by the mnemonic camp. That is C for the conus branch, AV nodal branch, marginal artery, these are the branches of the right coronary artery. See, this posterior interventricular artery provides blood supply to posterior one-third of the septum. Now this posterior interventricular artery branch supply would define the cardiac dominance. Now we move towards the left coronary artery. Left coronary artery divides into majorly two branches, that is anterior, that is left circumflex coronary artery. And here it is LADA. Now LADA provides two arteries, that is anterior interventricular septum arterial supplies by the LADA as well as, now it would be anterior wall of the left ventricle, anterior wall of left ventricle. Now left circumflex provides obtuse left marginal artery. Now what are the ECG leads that determine what is being seen? Now lead V1 and lead V2, that is anteroseptal, V3, V4, anteroapical, V5, V6, lateral wall. Now this is the pressure volume curve that we see now here at this point. So in this is the phase of isovolumetric contraction. So what happens is that atrioventricular valve closes, and in this period atrioventricular aortic valve opens. Now when aortic valve opens, then this is the ventricular ejection. Now here after that aortic valve closes. Now here there is isovolumetric relaxation, and here we have aortic ventricular valve opening, after which the blood comes into the ventricle and therefore volume increases, and this is the whole cycle. Now remember, when in these graphs, whenever it becomes thin, then we are dealing with stenosis, and whenever it becomes broad, then we are dealing with regurgitation. So here see what happens is that here there is isovolumetric contraction. After the contraction phase, it is ejecting very rapidly, and whatever it is ejecting, it is not being able to empty itself fully. So here what we are dealing with, this is aortic stenosis. Also remember that here the end diastolic volume is more. Also in aortic stenosis there will be increase in afterload. Now we move on to the second graph. This is, and this what is happening as soon as the atrioventricular valves closes, instead of isovolumetric contraction, there is increase in its volume. That means that it has the ventricle has blood accumulated in excess of its capacity, and this is aortic regurgitation. Why? See, in aortic regurgitation there will be ultimately increase in preload, and that is what is occurring here. So somewhere here aortic valve opens and it ejects rapidly, and here aortic valve closes, but still the volume is increasing, which shows that even after the aortic valve that is closed, the blood is being pushed backwards. This means that we are dealing with aortic regurgitation. And now here what will happen at this point, that aortic ventricular valve opens, and then there is increase in its pressure. Now we move on to the next part, that is left ventricular pressure. So what is this we are dealing with? See, at this point what will happen? This point, see, it is getting thin, so we know that we are dealing with stenosis. It is getting here thick, we are dealing with regurgitation. Now what happens in stenosis? Now here atrioventricular valve closes, and then here there is increase in the left ventricular pressure because of isovolumetric contraction, and here aortic valve opens. So what is happening here is that when aortic valve closes, now what happens is this is a here the aortic valve closes, and what we are witnessing now, we should end systolic volume. What is ultimately the end systolic volume here? End systolic volume is lesser. That means the left ventricle is not filling fully. That is, we are dealing with mitral stenosis. Now in regurgitation, remember that this here the aortic valve closes, here then the aortic valve opens, and then when it opens, it pushes the blood a lot, and this here aortic valve will close, and here again atrioventricular valve will open. So what is happening is here is that there is increase in the ultimate volume of the but similarly aortic regurgitation, mitral regurgitation would appear to be similar. But remember here that in mitral regurgitation, the blood in the left ventricular wall is decreasing with respect to the standard. That is, whatever amount in the blood there was in the ventricle, there is lesser blood. Why lesser blood? Because it has been regurgitated through the mitral wall. So how will you differentiate with aortic regurgitation? Now here in aortic regurgitation, remember that here aortic valve closes. Now here again aortic valve opens. So aortic valve when closes, it pushes the blood forward, and this push of blood forward results in aortic valve opening, which is manifested here. So here whatever the standard pressure was before, the standard pressure is continuing afterwards also. In fact, it is greater than whatever the pressure was earlier. So what does it mean? It means that there is excess of blood in the left ventricle, and this is shown in aortic regurgitation. Now for this, remember that here the peak has gone a lot above what was the standard. So this is seen in pulsus parvus at tardas. Now this pulsus parvus at tardas, it is seen in aortic stenosis. This is bounding pulse. This is bounding pulse. This is seen in aortic regurgitation. Now here, this is the bounding pulse, as we are seeing that it is a peak large pulse pressure, and therefore this is known as aortic regurgitation because we are seeing a lot of large pulse pressure. Whereas in pulsus parvus at tardas, there is not much pulse pressure difference, but the peak has gone beyond what it was now physiologically normal. Now we come on to the next part here. See this, the green part, whatever the green part they are shown here in this diagram, that is referring to that is left atrium. Now left atrium, and the black one below is left ventricle. So what is happening is there is left atrial pressure is greater than left ventricle at certain point of time. This is only possible when there is mitral stenosis. So the pressure in the left atrium is then more at the left ventricle. Now after that mitral stenosis, here it can be mitral regurgitation. What happens is there in mitral regurgitation, remember that whenever there is systole, there was increase in that would lead to increase in the pressure in the left atrium. So when there is a systole happening, when the graph is moving downwards, then also it pushes the blood into the atria, and ultimately tall V wave is seen. Now tall V wave is seen because of ventricular contraction occurring. Now here is the JVP study. In JVP we have A wave, C wave and V wave, and we have X descent, Y descent, A for atrial contraction, B, C for tricuspid bulge, and V for the ventricular contraction, and we have rapid X descent, and then we have Y descent. Now A wave absent. Now where is A wave absent? One thing also remember that in that P wave is also absent in ECG. P wave absent in ECG. What we are talking about? We are talking about atrial fibrillation. So remember that A wave sign is A wave is absent in atrial fibrillation. Now prominent A waves. Now what are the when will you get prominent A waves? Either there is some thrombus, there is tricuspid regurgitation, there is pulmonary regurgitation lesion, or there is some pulmonary arterial hypertension. Then also we will get prominent A wave. Canon A wave is when the atria is contracting against the ventricle and it is just contracting and nothing is moving forward. So as there is the block and there is the energy transferred, so it will, after striking the atrioventricular valves, they will see that the impulses is now passing more freely, so they will travel backward and called Canon waves. Now there is premature junctional beats also associated with it. Now remember, we can remember by the mnemonic plate axis. Now in plate axis, remember that P is for the pericarditis and T is for the tamponade. So plate axis, that is pericarditis, will have Y descent prominent, whereas in tamponade it will be X descent prominent. Now remember the tricuspid regurgitation separately because it confused a lot. Remember CV, Y in TR. That is, we will see the prominent C wave, prominent V wave, and with the Y descent, and nothing else is visible in tricuspid regurgitation. So what will be the wave like? See, this is atrial contraction. So there will not be much atrial contraction. Then this is ventricular contraction. This is now ventricular contraction. What is the shape of a normal carotid pulse? It is somewhat like this, and the arterial pulse would be like this. So what happens in various diseases? Remember that in hypokinetic pulse or in aortic stenosis, the pulse we will get is that is less prominent. So what happens is there is decreased volume of blood that is being pumped. There is being pumped. This is a decreased volume of blood that is being pumped, and this is known as, this is witnessed in hypokinetic pulse. Now we move on to the next. Now remember, this is the of tricuspid regurgitation. What happens here is that we see C wave, V wave, and Y descent in TR. But this was regarding JVP. Now again we come back to the pulse. Now in pulse what happens is that, now this is known as pulses bisvariance. Now in pulses bisvariance what will happen is that there is bifid pulse that is being seen here. Why is it so? Because there is aortic and ventricular dissociation. That is, aorta and ventricle are dissociated. This is known as bigeminal pulse. This is known as bigeminal pulse. Now what is pulses bisvariance? Now in pulses bisvariance, that is, now pulses bisvariance is a outflow tract problem. What happens is that there is number of peaks, and then again the number of peaks. Why? Because there is pulses bisvariance obstructed. Now this is pulses ultrans. Now this is pulses ultrans. This is pulses ultrans. That is, there is continuous change in impulses. Now the other pulses, this is a bounding pulse. This is hyperkinetic bounding pulse that is seen in, this is known as water hammer or collapsing pulse. Water hammer or collapsing pulse. This is known as water hammer or collapsing pulse. Now this is, you remember that this is collapsing, this is bounding pulse. Why it is called bounding pulse? Because it is increased in volume and also there is considerable height to it, so therefore it is known as bounding pulse. Now this is because diagram, remember that there is P waves, then QRS, then T waves. Now between them, between P and QARS, we have the fourth heart sound, and QRS and T we have the first heart sound, and that is CX. That is what we will see in JVP, and then we have 2D and V3Y. That is the third heart sound wave. This is the second sound wave. Now systolic murmur. Now holosystolic murmur is which? Now remember that this is the holosystolic murmur. Now holosystolic murmur is seen in which part? It will be seen in aortic stenosis and pulmonary stenosis. Now we are seeing that this is the continuous pulse that we are seeing, and it is uniform. Then again we should see this is mitral regurgitation. See, when the mister hugs the wife, then it is migrating towards the axilla. One more thing that they will give in the question, that whenever they will have to talk regarding different valves, they will tell the where it is being auscultated. For example, this is the sternum. Now in this sternum, towards the right side in the second intercostal space, we look for the aortic, and for second intercostal space, we look for the pulmonary. Now we move on to the fourth and fifth intercostal space. Now on fourth have this, fifth have this. Fourth we have tricuspid valve, and fifth we have mitral valve. So these are the areas where one can auscultate and listen. So remember that in mitral regurgitation it is moving towards the axilla. Holosystolic murmur, aortic stenosis, and pulmonary stenosis, this was radiating towards the base of the heart. Whereas mitral regurgitation, we have hugged the wife, so therefore it is in the axilla. But mitral regurgitation would be heard in which place? Mitral regurgitation would be in the fifth intercostal space here. Now here this is mitral valve prolapse. That is up to a particular certain point that mitral valve was obstructing, but after a certain point mitral valve stops, and after that it prolapses. Now this is a holosystolic murmur. Now this is holosystolic murmur. This is holosystolic murmur. Seen in ventricular septal defect. Now we come on to the diastolic murmur. Now in diastolic murmur, remember the one the sound is immediately after this S2 closure. That is, now when we talk about the diastolic murmur, remember that we have the mitral stenosis that also is on the that also. So remember, as we had talked earlier, that OS is referred to the opening snap, and opening snap is when we are clapping for MSD, that is mitral stenosis and diastole. So here it is diastole, and there is an opening snap that we see, and that is the thing that we can remember. That Mahendra Singh Dhoni is chilling inside the dressing room and not coming outside. So whenever he comes outside, the crowd goes wild, and they clap a lot. Now this is the continuous hollow systolic as well as diastolic murmur. This is seen in patent ductus arteriosus. Now benign flow murmur in babies is known as Still's phenomenon. Now we have Graham-Steele murmur. Remember that we can remember this by grandpa. Now in grandpa there is pulmonary hypertension, and this is the murmur due to pulmonary hypertension. Now we have then Carey Combs murmur. As you know that Alex Carey is a wicketkeeper of Australia. So you know that in the wicketkeeping requires a lot of squatting, and this leads to pain in the knee, and he has been out of this many series because of the pain in the knee. So that is rheumatism. So Carey Combs murmur is seen in rheumatism. Now we have Austin Flint murmur. This is because of aortic regurgitation. And the question that is often asked is that when the heart sound is loud or when the heart sound is mild. Now the first heart sound includes the mitral and tricuspid valves closure. The intensity of S1 is determined by the distance that the leaflet of the valve will have to travel to the annular plane, left ventricular contractility, and the PR interval. So loud S1 can be caused by early mitral stenosis. Why we are saying early mitral stenosis? Because after when fibrosis happens, then its mobility reduces, and since its mobility reduces, the mobility reduces. Therefore, then the sound of the heart valve is low. So therefore we are here saying early mitral stenosis, mild mitral stenosis, and hyperenergetic states. That is when we have hyperdynamic circulation, that is in thyrotoxicosis, anxiety, anemia, pregnancy, and exercise. And when we have short PR interval, then everything is happening very fast. And when everything is happening very fast, then it will produce a loud sound. Now soft S1 on MS. Now remember that in first degree heart block, mitral regurgitation, soft S1 in MS is due to mitral regurgitation, aortic regurgitation. Since there will be aortic regurgitation, mitral valve will not open to its fullest. Attenuation is due to increased tissue in between the heart and the chest wall. Now calcified mitral stenosis, there is no closure properly, left ventricular contractile dysfunction, and beta receptor blocker, decreased impulse rate. Now remember that there are certain bad side maneuver which have effect on the intensity of the sound. So when there is inspiration, there is much negative pressure, increase in venous return to the right atrium, then inspiration would lead to increase in intensity of the right sided sounds. Now hand grip is what it will be against the obstacle. So there would be increase in peripheral vascular resistance. Now in hand grip, remember that when we are applying a hand grip, then what is happening? Then the peripheral resistance has increased. Now when the peripheral resistance has increased, then it will transfer back into the hospital in form of mitral regurgitation or aortic regurgitation and ventral septal defect murmurs. All the three in an individual is really life-threatening, and very skillful surgical procedures are required. Now we move on to the Valsalva phase 2, standing up. What happens is that there is decreased intensity of most murmurs and increased in intensity of HOCM, MVP, earlier onset of click or murmur. Now remember when Valsalva phase 2, then when the person is standing up, so remember when he is standing up, then there is decrease in preload. So what is happening? Standing up, that is there is peripheral pooling of the blood, and ultimately there is reduced systemic vascular resistance. And when this happens, then there is an decrease in intensity of most murmurs and increase in intensity of HOCM. See, remember, as Chief Minister would not like standing up time and again in the Parliament. So what he does is that since he is not a member of the Lok Sabha, so he kind of manages and develops HOCM clinics. And now when we do rapid squatting, remember in rapid squatting RS is coming now Rajya Sabha, and for Rajya Sabha you know that CM has no value, so HOCM value is almost nil in cases of rapid squatting. Now let us move on to the murmurs, how they increase or decrease. Let us go through here. So what happens when the person is carrying out Valsalva? See, Valsalva when happens, or when the person is standing, what is happening is there a man when standing, the blood will pool in the peripheral circulation, and therefore preload will reduce. So remember, there's a dictum that when the preload will reduce, that means the blood flowing to the heart is reduced. That means that the most of the murmurs that we are seeing will reduce, except HOCM and mitral valve collapse. I've already told you that when a chief minister is standing, then his murmur would increase because he would start speaking. So like that you can remember. Now, for example, in Valsalva, after Valsalva, the person passively leg is raised. This results in increased venous return, which results in increased murmur. Again, there are two exceptions, HOCM and mitral valve collapse. But now if the person is sitting down, then the afterload is increased, and when the afterload is increased, then the murmur would increase, except HOCM, mitral valve collapse, and aortic stenosis. Now aortic stenosis is a new addition here, and in place of sitting you can also write that hand grip, because when hand grip is there, then there is peripheral increase in resistance. So not only sitting but also the hand grip. Now with the next situation is afterload is reduced. How? By bringing the peripheral vascular resistance down by administering the MRE nitrate. Now when MRE nitrate is administered, so what happens is that afterload will reduce, and when this afterload will reduce, the murmur will decrease. Now we move on to the next Mary's law. Now what is Mary's law? In Mary's law, BP is inversely proportional to heart rate. After that, we move on to the next segment, that is brain bridge reflex. Now remember that brain bridge, it is a bridge that is joining something. When it is joining something, so it will increase. That is, increase in venous return results in increase in heart rate. Now we have Bezold Jerry's Remember that Zold. Now here it is Zold giving. So there will be reduced in heart rate as well as in reduced in blood pressure. Mediator is capsaicin. Now let us move on to the next disease. That is, in this we have pericardial disorder, constrictive pericarditis. Pericardial disorder, constrictive pericarditis. Now in pericardial disorders, remember that 8 tracks. In pericardial disorders we have here cardiac tamponade. Understood? We have 3 problems: cardiac tamponade, constrictive pericarditis, and acute pericarditis. Now we know that 8 axis is the formula. That is, constrictive pericarditis, Y wave will be prominent, and in cardiac tamponade. Now in pericardial disease, what we will get is that Ewart sign. What is Ewart sign? That suppose this is the true scapula from the back side. So when we do percussion in between these scapula on the back side, we will get a region of dullness, and that is known as Ewart sign. Moreover, the other things that we get here is backstride, hypotension, muffled heart sound, and on ECG we will get electrical alterance. Why? Because in the tamponade, the heart will jump from here to there, and therefore it will bring alternating voltage, and therefore we will have electrical alterance. Now in constrictive pericarditis, remember Y wave is prominent and X wave is not prominent. Now here we get pericardial knock because it is all constricted a lot. So here we will get pericardial knock, pulses, paradoxes, raised JVP, low voltage ECG. Now in acute pericarditis, what we will have? Pericardial rub, global depression in ECG. Now what is pulses, paradoxes? Pulses, paradoxes is when we raise our arm during inspiration, there is usually loss in the blood pressure reduces less than 10 mm of mercury, but in certain circumstances, now pulses, paradoxes is associated with asthma, tamponade, pregnancy, and all other such kind of diseases. So, one thing that you would be all curious about, that why there is X wave prominent but not Y wave prominent in pericardial tamponade. Remember that in pericardial tamponade, ventricular or diastolic filling is impaired. So when ventricular filling is impaired, so what happens is that blood gets stagnated, and when blood gets stagnated, we do not get the descent. Now we move towards the cardiac pathology. Now this is Aschoff body seen in rheumatic carditis. This is dilated cardiomyopathy. This is hypertrophic obstructive cardiomyopathy. Here see the fibers are spread here and there. This is an infarcted heart which was stained with NVT, and this whitish area on this shows the infarcted part. Now one should remember what are the before moving forward, let us dive something more deeper. This dilated cardiomyopathy can be under the influence of alcoholism, tight gene mutation, ninja star appearance. In Aschoff body, remember, we will get caterpillar cell,